Welcome to the Authority File. I'm Bill Mickey, your host and the editorial director at Choice. In many ways, the response to COVID-19 has been a wake-up call for citizens and governments around the world. In the last 10 months, researchers tracking data related to the spread of COVID-19 have come to a new understanding of how policies, legal systems, and governance have responded to the virus and how these have exposed vulnerabilities in our infrastructure, institutions, and most importantly, the people who are most susceptible to the virus and more likely to die from it. In fact, the manner in which many countries implemented their COVID-19 responses actually exacerbated vulnerabilities in certain populations. My guests for this series have compiled a volume that explores one country's response to COVID-19, Canada's. It's written primarily from a legal perspective, but grounded in governance, accountability, civil liberties, equity, labor, and global health. The book is called Vulnerable: The Law, Policy, and Ethics of COVID-19, published by the University of Ottawa Press, the sponsor of this series. While the title focuses on Canada's response to COVID-19, it includes a global perspective on the ways in which governments can and should prioritize their policies in responding to and recovering from a pandemic, pulling together experts in law, ethics, philosophy, public health, and medicine. Joining me are the book's editors, Colleen Flood, who is the University of Ottawa Research Chair in Health Law and Policy and inaugural Director of the Ottawa Centre for Health Law, Policy, and Ethics. Vanessa McDonald is Associate Professor at the University of Ottawa Faculty of Law and Co-Director of the U Ottawa Public Law Centre. The Honorable Jane Philpott, who is Professor of Family Medicine, Dean of the Faculty of Health Sciences, and Director of the School of Medicine at Queen's University in Kingston, Ontario, and served as Canada's Minister of Health from 2015 to 2017, and then Minister of Indigenous Services from 2017 to 2019. Sophie Thériault is full professor and vice dean in the Faculty of Law at the University of Ottawa. And Sridhar Venkatapuram is an academic practitioner in global health ethics and justice. He is associate professor at King's College London and director of global health education and training at the King's Global Health Institute. Since we were fortunate enough to speak with the whole team of editors for this series, we're dividing the group among the 4 episodes. In the first 2 episodes, we heard from Colleen Flood and Vanessa McDonald, who examined the pandemic response from governmental and legal perspectives. In episodes 3 and 4, we're joined by Jane, Sophie, and Sridhar, who address issues of equity and vulnerability. This is episode 4 of the series. If you missed the first 3, feel free to go back and listen to them and then pick up the conversation here. So, once again, here are Jane, Sophie, and Sridhar. Jane, I want to jump back to you. So between 2015 and 2019, you served in a number of federal cabinet positions in Canada, including the Minister of Health. I'd love it if you could provide us with a little perspective from that level. Generally, what, in your opinion, can be done at the federal level to fortify and better support frontline workers and the facilities they work in? You know, what might be some of the key policy considerations there?
Well, thanks for the question. It's a bit of a challenging one because, as you know, every country is designed a little bit differently in terms of who has responsibility and jurisdiction over healthcare.
Mm-hmm.
In Canada, we have a federated model, which is, one could argue in some ways not completely unlike that which you have in the U.S. It's a source of constant debate in terms of whether it's the most effective for the betterment of the health of the people of Canada. But one of the realities is that a lot of the delivery of healthcare in Canada falls to the provinces. Again, not completely dissimilar to some of the realities that you face there. A little different from Sridhar's circumstances in the UK, where there's a National Health Service that actually takes responsibility and authority at the for the frontline services at the national level. A few things I would say that the pandemic has really brought out in a big way is the lack of focus that we have had at a federal level on public health. And you referred to this a little bit earlier as well, but We have not had sufficient investments in public health in Canada, and most countries have been caught similarly off guard. But we also lack the authorities within the federal government to be able to do some of the things that would be helpful in the context of a pandemic.
Mm-hmm.
One of the big issues that I'm interested in is data. All around the world, people have struggled to various degrees in terms of their ability to be able to provide timely access to data to be able to determine what's going on and to sort of watch where the pandemic is moving. In Canada, our public health legislation does not allow the federal government, or does not give the federal government the authority to force provinces to share their data, both from a perspective of timeliness, but also in terms of the standardization of what that data looks like. And that was a little, one could argue, embarrassing in the early days when, we were trying to be able to figure out how many cases were actually happening, how many people were dying, how many hospitalizations or intensive care patients are there. So I wouldn't say that we've necessarily made an enormous amount of progress, although, people have pieced together mechanisms to be able to get a better picture of the data in as close to real time as possible. But certainly a policy consideration in the Canadian context is to be able to see a federal government that would be enabled to have the authorities to do that data work, but also to do the work that was necessary around the procurement of personal protective equipment and managing the supply chain from a federal level.
Mm-hmm.
So all of those things have certainly, we've paid the price to some extent. There are benefits, of course, of being able to have a slightly more nuanced response to clinical care, and we've seen that even at the sub-provincial level, that the response to the pandemic has been very different according to how of the epidemiology of spread over a period of time. But many people have suggested that this is an area where the federal government should have taken more authority than it currently has. But provinces here are not so inclined to give up the levers of what healthcare delivery looks like. So I guess the only other thing I would just point out there is that we also have faced some, I mentioned earlier that older people have been, as around the world, but Canada, I think, probably worse than most countries, the number of deaths that have taken place in long-term care facilities. And we have lacked a federal role in the delivery of long-term care. And in fact, most of it's actually delivered in private for-profit settings in various cases. And we've seen that the outcomes have been very much affected by the types of long-term care facilities. And there's actually a couple of really good chapters in the textbook that speak specifically to that.
Yeah, excellent. Sophie, I want to go over to you and just in sort of general terms, I mean, what would be the major features of an equitable response to something like COVID-19?
Well, yes, sure. At first, it will sound very basic, but I think it's very fundamental.
Mm-hmm.
And it's to think that an equitable response to COVID-19 first required to recognize and to take stock of the fact that we're not all equally affected by the virus and also by the responses adopted to limit its spread. I think it's very fundamental to recognize that we are all disproportionately impacted by the pandemic. So while, as Jane mentioned earlier, public health measures pertaining to confinement, isolation, and hygiene, for instance, are easily available for people who are able to afford a home. Many groups that are well documented in the book do not have such a privilege to benefit from a home with an internet connection from which they can work at distance. So For instance, taking people living in congregated or crowded space, including elderly people. Jane has already spoken about this issue in long-term care homes, group homes with people with disabilities, prisons, where there's been very well-documented outbreaks, both in Canada and the US, or people living in poverty who have to share crowded living space. Have very little choice to be exposed to the virus and are less able, in fact, to follow public health guidelines to protect themselves and to protect others around them. We should also mention, as I've done many researchers, including in the book, that some communities, including Black Canadians and Black Americans, are disproportionately impacted by the pandemic, both by the health impact of the pandemic and by the economic impact of the pandemic, which can be largely attributed to the nature of their occupations. Many of them, it's been mentioned, care for other people, so do care work, perform maintenance work, work with the public, and are therefore considered as essential worker. And in addition to living very often in conditions of poverty, where they do have to share crowded housing, poorly ventilated housing, many of them lacking private cars, and so on. All that to say that an equitable response to COVID-19 certainly requires to account for the specific and very often intersecting vulnerabilities of these different groups that need to be first documented. So we need to make evidence-based policies that are grounded in the real needs and circumstances of these groups. And also, to the risk of repeating myself, because I've said that before in this interview, but it's crucial that an equitable response to COVID-19 should seek to address these systemic inequities at the structural level, rather than bringing temporary band-aid solutions. So an equitable and sustainable response to COVID-19, in my view, would need to focus on the root cause of the pre-existing and intersecting structural inequities that have been laid bare by the pandemic, including those that are based on race, class, gender, age, ableism, just to name a few, instead of being based simply on punctual solutions that do nothing to address the underlying vulnerabilities that risk to present themselves again in the next crisis.
Great. Excellent. Thank you. Jane, there's a clear human capital issue here. And I'm wondering, how were staff such as those at Participation House viewed, in your opinion, as a workforce prior to the pandemic? And in contrast, how should industry and government leadership think about them differently now and going forward?
Well, that's a great question. I mean, I think some of the workforce that is necessary to be able to carry out services in a group home like Participation House was in many ways an invisible workforce. When the pandemic first struck, everybody immediately thought about emergency departments and intensive care units, and were there going to be enough doctors to be able to do that work? But very few people were saying, will we have enough personal support workers? And so, I think we're all guilty of taking for granted sometimes the most essential frontline workers. It took us a pandemic to realize that the clerk at the grocery store is one of the most important members of society when it comes to a workforce.
Right.
But the challenges in the early days, we kind of noted that, and there were significant efforts to be able to respond by, for instance, raising wages here in Ontario, Canada. We saw grocery store chains raising the wages of their frontline staff. We saw personal support workers and nurses and other hospital members of the health workforce getting pandemic pay increases. But in very few cases are those sustainable or intended to be permanent changes. So, going forward, we're going to have to think a lot more about what it takes to be able to support those essential workers, but also to make sure that training is adequate, that regulations are adequate. We really have lacked in terms of seeing those frontline health workers being able to have the same kind of regulatory colleges, for example, that we would have for nurses and doctors and other health professionals. So, leaders, what will leadership think about differently going forward? One can only hope that we will have changed our perspective on what it takes to keep a population healthy, and who are the people in our neighborhoods that we're most dependent upon, and how will we compensate for the risks that people have undertaken, but also how will they be rewarded for the fact that these are the people who have done the hardest work to keep us alive.
Excellent. Okay, so Sridhar, one of the issues, especially here in the States, I would think, is healthcare seems, all politics aside, an individual issue, not necessarily a social one. In other words, my health is my business. A particularly ugly version of this is sort of the reliance and promotion of herd immunity. And this individualism clearly poses problems when trying to get rid of a pandemic. Talk about how health as a social good is not only a good way to solve the problem we currently face, but could also greatly improve the health of a country's population overall. And I'm thinking, maybe we compare this to how we approach economic health, for example.
Okay, so fantastic. So let me just start off by then clarifying a couple of concepts. I hope that from this interview and from now on for the rest of your life, you will always separate health and healthcare. And healthcare is profoundly different from our concern for health. If we want people to be healthy, we don't build a clinic for them when they get sick. We also ensure that they are healthy and sort of focus on the determinants of health, but also protect them from determinants of disease and disability, etc. So one of the things that's happened in the United States and also in other countries as well is that when we focus so much on healthcare, and healthcare is considered to be what people call a consumption good, right? So people will want as much healthcare as they are able to pay for or need, etc. So that model where we focus very much on healthcare as a commodity that individuals get and they pay for, or we pay for their healthcare, has somehow erased this idea that our health is actually profoundly interdependent. And so the pandemic is a perfect illustration that shows you how we are interdependent, not only at a local level but at a global level. So let me give you very specific examples, which is that you have to be able, in order to be infected, you have to be near someone else, and you have to have certain kinds of exchanges in order to become infected, and then you take that somewhere else and you infect somebody else, etc. So that is a profoundly social phenomenon. And what we've done when we've locked down is not just this one thing where everybody's saying, oh, you can't work, but we've also locked down sports. We've not, locked down religion, arts, education, etc. So all of these things are social activities and social spaces that would promote more infections, and we are locking them down in order to prevent them. So it should very clearly, show us that actually our health, our vulnerability to disease is actually very much a social phenomenon. But that's also not only true for infectious diseases, we also now know that it's also true for chronic diseases as well. Is that what kind of chronic diseases we get and we suffer from, and even the healthcare that's available is very much reflected on lots of different things about our race and our class, gender, sex, age, sexuality, etc. and stuff. So those are all social things that determine our health and disability. So the idea that we have on the one hand a focus on healthcare, but on the other hand we're profoundly our health is profoundly socially determined, but also we have to now, in order to move forward, really accept and acknowledge the fact that in order to improve our health, whether it be going beyond this pandemic, but also after the pandemic, is that our health is interconnected. And one of the things that I hope that we are learning from this pandemic is that we always think about health and health policy as a national phenomenon. So it's a political agenda, and we think about NHS or Canadian health system or the US healthcare system. But actually, we now know that our health is connected to what's happening on the other side of the world. And we are vulnerable to what happens on the other side of the world. And importantly, what we do, it will impact the disease and deaths of people on the other side of the world as well. And so the more and more we recognize that, I hope then will result in our change in attitudes and our ethics and our policies that will try to not only address our individual health, but also recognize that it's interdependent with other human beings near and far, and what kind of policies do we need to implement in order to be able to move everyone to a place where their health will be protected. Sadly, the dark side and the way that it's going as of right now is that countries are essentially working on a winner takes all approach or a zero sum game approach, which is that first we protect our people and then we'll deal with other people's health or other countries' health, which we know is a short-term thinking, but it wins votes in a local level or at a domestic level. And then even within countries where there's a large country or disparate populations, it's a group like, let's protect our group first, and then we'll worry about everything else, or let's protect our political the group that we are representing, their interests first. And so this, I think, is going to be a profound challenge in order to move forward beyond this pandemic, but also to improve health in the future.
Excellent. Sophie, you touched on this a little bit earlier, but I'm wondering if we could drill down a little bit more and talk about what are the major systemic inequities that the Canadian government has yet to or refuses even to address in its response to the crisis.
Yeah, well, there are many. I'm sad we don't have all day. But I'll focus on a few that are well documented in the book. Well, the first one will touch on First Nations communities and Indigenous peoples more generally. So I already mentioned the well-known historical systemic inequities that are facing those communities and that are making them particularly vulnerable to the current pandemic. So ironically, while even during the pandemic, we're continuing to extract natural resources from their territories, putting them in danger of being infected by the virus by sending workforce on their traditional territories and also sometimes in their communities. Like decades-long housing crisis in many of those communities, decades-long water crisis are continuing to exist in those communities. Inequities in accessing healthcare is also continuing to exist in these communities, which make response to COVID pretty hard for them. In fact, ironically, last October, the government of Canada seems to have backtracked on its promise to make sure that all Indigenous communities have clean running water by March 2021. So there are still a little more than 60 communities in Canada that do not have access to clean running water in 2020. And that is known, that has been existing for decades. That's same month, a community, an Anishinaabe community in Northern Ontario, in fact, was completely deprived of any kind of running water as its system failed. That community has been on water boiling advisory for many decades. So there's been an historical lack of responsiveness to Indigenous systemic inequalities. And this is continuing during the pandemic as the government has adopted some like punctual ad hoc emergency measures, but have yet to announce a comprehensive plan to tackle all those structural inequities that make Indigenous peoples very vulnerable.
Mm-hmm.
Related to that, Canada has yet also to adopt a policy, a strong policy to guarantee access to adequate, safe, affordable housing for all, which is another source of systemic inequalities that make many people in our society vulnerable to COVID-19. So Canada has struggled since many years with increasing rates of homelessness, especially in cities where the price of housing has increased tremendously, thinking of Toronto, for instance, or Vancouver. And like where people cannot access vulnerable housing. So at this moment, we have hundreds of thousands of people who are vulnerable to public health crisis and environmental crisis because they cannot access to affordable, adequate housing.
Mm-hmm.
And finally, we'll finish with the workforce. We already discussed this with Jane. It was the pandemic really made it laid it bare with elderly people in our long-term care homes, but also with the workforce, with the people who are, for many racialized people, who are underpaid and overworked, or taking care of our elderly people. We also have very precarious people who have been vulnerable in the pandemic through labor conditions that are very precarious, including racialized people, new migrants, and temporary worker in the agro-food industries. That needs to be addressed at the systemic level by the Canadian government. So we need a real overhaul of our labor conditions laws in order to make sure that everyone can work in dignity and in security, and make sure that like conditions that make us all very vulnerable to public health crisis. As Sridhar says, we are all interdependent.
Excellent. And Sridhar, how does the way a society allocate resources reflect its views on equity?
Yeah, I think that the first, I'm going to narrow that question down to something more manageable and sort of talk about not society in general, but how a government allocates resources. I think number one, one of this, I really love this quote that I remember a colleague of mine, Joe Wolf, had said, is that the government doesn't have any money; it has our money. And so this is a really important point, is that we entrust our taxes and our resources to the government so that it and the politicians and policymakers are allocating resources so that they serve the public interest. And so how it allocates those resources inherently has different kinds of notions of equity in it. And one of the things that I think Sophie and Jane and I have been pointing out repeatedly is that there is a problem here about how at least the countries that have not done well, how they think about equity in policymaking. And to put it simply, what I would say is that they imagine that they are making policies for a standard citizen, and they imagine that they're making a policy for a certain individual, usually middle class. They have housing, they have a job, and they have this and they have that, and that policy will then be implemented because they're also thinking this is the largest group of people, so they are also the average standard citizen, and then we'll deal with everybody else later, or as a separate special policy consideration. So it's a condition of equity, I guess. If we were thinking philosophy, this is the idea that public policy is about the greatest number for the greatest good. And so we will try to act quick and help as many people as possible, and then we'll deal with all the exceptions and the consequences later. And I think that this is profoundly mistaken, and it has a lot of problems, and we are seeing what those problems are, both in the sheer number of deaths, of preventable deaths of people but also the suffering that is being endured by groups within population. But also, let's also remember that women are not a minority group, and the impact on women in the domestic household is a result of lockdowns in terms of having to do all the childbearing and house cleaning, but also working a job. That is not a minority issue. That is how we're sort of dealing with, even among the middle class majority people. This is a significant stuff. So it shows, I think, the weaknesses of the policy-making model in the way that we distribute benefits and burdens is that we imagine it to be kind of this, standard average citizen, and we make that policy and then let other people just sort of deal with it, and we'll deal with them later. And I think that we need a much better way. And as Sophie said, it's a question of dignity, and that policy should be more tailored. And I think that there's a lot more to be said about that, which is that, every citizen has a right to equal concern by the government. And the government should be thinking very clearly and very directly about what their particular situation is and what particular situation of different kinds of groups are, and tailoring and modifying policies that are directed towards them. And I think that's stuff. But when it comes to when a government realizes that, there's this one specific group of people that are the key to everyone else, then they'll tailor that intervention to that specific group. Mm-hmm. But if it's just about their interest and well-being, then they're sort of secondary to the average citizen as a priority. And I think this has to change, or at least I think that this is going to be something that I'm going to be thinking about for a long time.
Right. Sophie, anything you'd like to add to that?
No, I would simply come back to how Sridhar put it, as our health is all interconnected. So public health is closely related, in fact, to social and economic equity. So it's well known that health indicators are lower for a marginalized group, including people living in poverty, racialized people, Indigenous people. And in the context of a public health crisis, as we are learning in the context of COVID-19, the systemic inequities that create a fertile ground for outbreaks and community spread of the virus makes us all vulnerable. So a healthy and sustainable society is therefore also an equitable society. So we need to have policymakers and government that are sensitive to equities and are determined to prioritize social equity if we want to have a healthy society.
Excellent. Okay, well, that's all the time we have, and thank you all for joining us on the program. You just heard from the Honorable Jane Philpott, Sophie Theriault, and Sridhar Venkatapuram, co-editors of the book Vulnerable, The Law, Policy, and Ethics of COVID-19, published by the University of Ottawa Press, the sponsor of this series. This episode concludes our 4-part series on the book. If you missed the first 2 episodes, go back and listen to them. You'll get a chance to hear the other editors of the book, Colleen Flood and Vanessa McDonnell, discuss the pandemic response from governmental and legal perspectives. In episodes 3 and 4, we were joined by Jane, Sophie, and Sridhar, who addressed issues of equity and vulnerability. If you like what you hear, rate us or give us a review on your podcast platform of choice. And if there's a topic you'd like us to cover, drop me a line. I'm at bmickey@ala-choice.org. As always, sponsorship and advertising for the Authority File podcast are handled by Choice's advertising manager, Pam Marino. And all of our episodes are produced by Choice's senior digital media producer, Mark Dirks, and digital media assistant, Sabrina Kofer. That's all for this week. Thanks for joining us.